Good evening and welcome to the San Mateo County Dental Society Member Symposium. It looks like we have a great audience joining us tonight. My name is Ben Yount and I'm the president of SMCDS. Before we get started, I want to review how we will be running this meeting. All participants will be placed on mute. Our presenters will provide presentations on TMD, orofacial pain, and the opioid crisis in America. During the presentation, you may post a question into the question and answer box. For those participants on your desktop, the question and answer box is located on the bottom of your screen. For those on the iPad or iPhone, the question and answer box should be on the upper right. Please feel free to post your questions if time permits. We will go over them at the end. So now, let's get started. We're pleased to have two very experienced presenters with us tonight. Mark Abramson is our first presenter. He graduated from UMD School of Dentistry in 1975 and was in residency at the Palo Alto VA Hospital in 1976. Dr. Abramson is board certified by the American Board of Orofacial Pain and American Board of Dental Sleep Medicine. Dr. Abramson is the developer of the Oasis and Oasis Hinge Appliance. Mark Abramson established the Stanford's Mindfulness Clinic in 1996, and he's recorded webinars for ADA and the Stanford Corporate Partners. So please, thank you, and welcome, Dr. Abramson.
Thank you. Welcome everybody virtually. We're going to look at this amazing system that we're all involved with, and I hope one of my goals is that you gain a new and fresh appreciation for the both the intricacies that you work with all the time and the healing potential of the working with this system in ways that help growth and development. I want to start with looking, first of all, disclosure that I developed two appliances for treating sleep apnea that are FDA cleared and do have a dental laboratory that does manufacturing of oral appliances and splints. And I also have a number of patents, including one of the tongue guides for splints that I'm going to be talking about tonight. But generally, I'm a wet-fingered dentist. I don't do fillings and root canals and all that good stuff you do. I do integrative medicine approach to craniomandibular issues. And so let's look, first of all, at the anatomic considerations of this amazing system that we work with and look at the evolution. To get upright, we had to make some very important changes from the bottom of our feet, the big toe becoming straight, the movement of the gluteus maximus muscle to our wonderful butts instead of the sides of our thigh, the curve of our spine, and then the upright posture of our neck that required a jaw that translates, because of if we were in rotation, we would have impinge on our airway. So we had to loosen up our whole jaw and throat for both upright posture and speech. They kind of came together. So the curve of the spine, but more important to us is the translation of the jaw. So in all other mammals that we share the planet with, the temporomandibular joint is a pure rotation. It's bound. And in humans, we have this translation. And if we think about it, these are two joints working together under tremendous muscle power and need for exquisite coordination and proprioception to feel where things are in your mouth and to bite down properly and to function normally. So I opened a TMJ Orofacial pain clinic at Stanford with Sabine Giraud, and we did a presentation with the community at the faculty club at Stanford. And I made the comment that translation of the mandibular condyle was an evolutionary thing for function of the jaw and the airway. And somebody challenged me there. And at the time, I just was putting a number of things together. But there's a book that I got from a friend that had the first full discovery of Homo erectus. It was actually an 11-year-old child. I wrote the authors and said, tell me what you know about translation in the Homo erectus. And he said, well, he really never thought of looking at that, but he referred me to this book. And sure enough, there's just what I wanted to see. There's little medial-lateral movement possible in the ape cranium. Why? Transitory movements of the head of the mandibular condyle in apes are bound. Chimpanzees do not exhibit translation. Voila. The reason is because they don't have to. Why would nature make a complex joint when a simple, more stable joint would suffice? So in all four-legged animals, your dog or cat, or chimpanzees, which you could say are knuckle walkers, their head and neck is a 45-degree angle. But what's really significant is their throat is behind their jaw, so their jaw can still translate without cutting off the airway. But our jaw, if it was pure translation, like happens in sleep when your jaw drops open, it's a pure translation, and it causes sleep apnea by blocking your throat. So we had to develop translation and a number of other things. So as we developed and grew to upright posture, the foramen magnum came forward and the maxilla came back, so that the foramen magnum is now centered at the 6 o'clock position of this bowling ball. And even our chin is an adaptation for this. So chimpanzees have a simian shelf because they can afford to have the bone to strengthen their jaw on the inside. As we evolved to more upright posture, again, that bone on the inside would have taken up space of your airway. So we had to create the strength of the mandible. And so evolution took care of that by developing a chin. So if you look at chimpanzees, they don't have chins and they don't have your beautiful buttocks. So the temporomandibular joint has an intimate relationship with other structures, particularly the ear. They're basically conjoined twins. So if we look at reptilian jaw, that we see that the reptilian jaw, they only have one bone in the middle ear, okay? We have 3. What's happened is that the quadrate bone of the jaw of the amphibian got incorporated into the middle bone of the ear, the incus. And the malleus was evolved from the articular bone. So basically what happened is the jawbone of the amphibians was incorporated into the ear of mammals. And so we have a lot of structure that came with it, the nerves and the ligaments that came with those bones into the ear. So the trigeminal nerve and the jaw and the ear are literally continue to be coordinated, conjoined twins. So the temporomandibular joint is a unique feature in mammals. No other vertebrates have it. So the muscles of the mandible, so we have the temporalis, and you all know this from your anatomy, that originates from the temporal fossa and inserts in the coronoid process of the mandible. But this is divided into 3 groups that kind of function independently. So we have the orientation of the anterior group that's more vertical for closing, the middle, which is more oblique, and the posterior, which is almost horizontal. And they all pull on the mandible in different directions. We have the masseter sling, and we have a deep portion of the masseter, and the superficial. The masseter's superficial and deep portions originate from the zygomatic arch, and they, the superficial portion attaches to the external surface of the angle of the mandible and the inferior halves of the ramus. The deep portion attaches more superior of the ramus, posterior to the second molars, with a more vertical orientation. Okay. Then on the inside of that sling with the masseter, we have the internal pterygoid, which originates in the pterygoid fossa, in the medial lip of the lateral pterygoid plate of the sphenoid bone, and inserts in the angle of the mandible on the medial surface. And it forms a sling with the masseters to exert strong closing forces. when used unilaterally, from the contralateral side, it will move the jaw into both together will move the jaw into protrusion. So we have the intertemporal fossa to the mandible. So basically we have a sling of the closing muscles of the jaw, which are very powerful. And then we go to the external pterygoid, which this has two bellies. The superficial belly is smaller, arising off the intertemporal fossa. See if I have an arrow there, yes. And it goes to the greater wing of the sphenoid, extending horizontally out, and it attaches to the mandibular condyle. 85% is also is attached to the articular disc, and 15% is attached to the articular disc. And it's interesting that this muscle acts on closing to stabilize the disc to the posterior slope of the eminence in closing. And this is a very important consideration because we've had a lot of controversy in dentistry about centric relation that we want to talk about, because I think that the new understanding of what true centric relation is a very much healthier position, and it can really make the difference between being successful with a case or actually creating more problems for the patient. Okay, then we have the inferior belly, which is larger and originates in the outer surface of the lateral pterygoid plate of the sphenoid, extending back up and out and inserting on the neck of the condyle. This muscle opens and protrudes the mandible when bilateral, and lateral movements to opposite side when unilaterally contracted. So here's the two bellies of the internal pterygoid muscle. Okay, and then we have the suprahyoid muscles. So when people talk about the jaw, I describe the jaw as part head and part neck. So we have to realize that we have important connections with the neck in speech and swallowing and in airway. And so we have the suprahyoid muscles, the digastric, the myohyoid, the geniohyoid, and the stylohyoid muscle. So we have the digastric, the posterior belly, and in the middle we have an intermediate tendon that holds that sling to the hyoid bone. And then we have the myohyoid, which is the part we palpate, inside the mouth, and the geniohyoid from the genial tubercle to the hyoid bone, and the stylohyoid, which is a muscle from the styloid process to the hyoid bone. So this is our sling of the neck and the jaw. So in opening, the inferior head of the lateral pterygoid and interior digastric and myohyoid help opening. And to recognize that opening is a much weaker movement. I mean, if we had an alligator, we could hold with our hands to keep him from opening his mouth, but we sure the heck couldn't keep him from closing his mouth. So the opening doesn't need much force. But it is a complex movement with early rotation component and then translation of the axis of rotation forward. The articular disc moves forward with the condyles as it glides forward, effectively extending the superior articular surface of the mandibular fossa over the eminence. In closing, the masseter, anterior and middle temporalis, medial pterygoid, superior head of the lateral pterygoid, which is again attached to the articular disc to stabilize it in the inner slope of the eminence. Protrusion is bilateral contraction of the lateral pterygoid. Retrusion is the middle and posterior temporalis, possibly helped by the deep posterior portion of the masseter. Lateral protrusion moving side to side is an ipsilateral middle and posterior temporalis, the contralateral inferior head of the lateral pterygoid. And just to emphasize that lateral movement like we have is also unique because of the translation of the condyles in humans. So we have this ability to move laterally. The ligaments that support. Now, recognizing that ligaments limit movement and stabilize a joint through the limitation of movement. So we have the capsular ligament, which surrounds the whole temporomandibular joint apparatus. And then we have the the medial and collateral ligaments that are the lateral support of the disc itself. And then the temporomandibular, we have the inner horizontal and the outer oblique ligament, which limits opening. So basically understanding that ligaments give support and limit movement. Now, on the inside, we have ligaments that are attached to the malleus. Again, this is from that movement of the the jaw of the amphibian into the middle ear. So we have the discomallear ligament, which is also called Pinto's ligament. We got the PML fibers from the sphenomandibular ligament, nerve, and PMAL. So we have these ligaments that are attached into the ear from the jaw, and we also have the pterygoid mallear ligament, which again is limiting opening of the jaw, the sphenomandibular ligament. Okay, so here's another picture of the sphenomandibular ligament from the sphenoid bone to the lingula of the mandible. And then we have the stylomandibular ligament, that's the styloid process to the posterior angle of the mandible. And these act as brakes, preventing excess anterior drift of the mandible during extreme opening, and it is subject to hyperextension injury and like a whiplash that can make the jaw too mobile. So we have some syndromes that have to do with those ligaments, which are part of the temporomandibular disorders of pain that we might see clinically. And we have Ernst syndrome, which is a painful complex of reproducible symptoms related to the insertion of the stylomandibular ligament on the mandible. The stylocarotid syndromes, another name for this, because it basically impinges on the carotid artery, and is sometimes called carotidynia, are due to compression of the internal and or external carotid arteries, especially their perivascular sympathetic fibers, resulting in a persistent pain radiating to the carotid territory, as headache, chronic neck pain, pain upon turning the head, and pain radiating to the eye. Ear pain, vertigo, and other symptoms are possible presentations of this. Then we have Eagle's syndrome, which is a calcification of the stylohyoid ligament, which is characterized by sudden sharp nerve-like pain in the jawbone and the joint in the back of the throat and the base of the tongue, triggered by swallowing. So these calcification of the ligaments of the stylohyoid ligament is a frequent and often incidental finding in radiographs. So you might see these in your Panorex patients, or you don't need a cone beam CT, but we're going to show you some examples of this. So this is the stylohyoid muscle and the stylohyoid ligament, and you can see its connection to the carotid internal and external carotid arteries. So this is some x-rays that I took, which is a calcification of the stylohyoid ligament, and you can see how long that is. This is a Panorex showing that, and you can even see joints in this ossification, particularly on the right side here. And this is a cone beam CT of that calcification with the joint in the ligament. So this is something, as you're looking at your Panorex x-rays, you know, look and see if you see any indications. There's not much to do with this, but it certainly can give patients kind of guidance to manage the problem. So we have this important trigeminal nerve that we all know about. Sometimes we know too much about. And so we have the three branches, the ophthalmic, the maxillary, and the mandibular branch that we studied very hard in school. But what I want you to appreciate is, remember that old homunculus, that when we see that there's two ways to visualize that, the clay model and the laid over the brain. So if you look at the sensory and motor areas of the body and how much real estate is dedicated to different parts of the body, you see that the mouth and the throat are about 38% of the real estate in the sensory motor parts of the brain. So we're working with an exquisitely sensitive area. And you know that I have a friend who's a physician, just retired, but his specialty was headache. He had a headache clinic in Mountain View. And he called me up and he started telling me about these pains he was having. And he wanted some friendly advice. And turned out he just had a crown done a couple months ago. And so I asked him, I said, well, just touch gently down. Are you hitting that crown first? And sure enough, he was. And I said, well, it's throwing off the proprioception and now your muscles are reacting to that. So one of the ways I describe this is that we all have this experience. You go in the restaurant and the table tips. Well, if we could go in restaurants, and the table tips. And it's not much of a movement. It's just you touch it and it just shifts a little bit, but it drives you crazy. And so what the brain wants with proprioception, which is basically feedback from all the information coming from the body about space, about contact, about relationships, is we want stability. So you get the waiter to come over and you put something into to the leg that's wobbling and stabilize it, and then you don't think about it anymore. Well, he went back to his dentist, got the crown adjusted, and he emailed me and said, thank you, I'm perfectly better now. We see this all the time, is that, well, if you have a crown a little bit off and then patients come back with a complaint that sounds bigger than you think it should be. So we have little tiny muscles in the ear that are also part of this system. So the stapedius is the tiniest muscle in the body. It's less than 2 millimeters long, and it's located in the middle ear. And the function of this is to control the movement or vibration of the smallest bone in the body, the stapes, or the stirrup bone. And it's innervated by the stapedial branch of the facial nerve. Now, the tensor tympani is a muscle, another muscle within the ear. It's contained in the bony canal above the osseous portion of the auditory tube. Its role is to dampen sounds such as those produced from chewing. Contraction of the tensor tympani muscle pulls the handle of the malleus inward, and as its name of the muscle suggests, tenses the tympanic membrane. It's innervated by the trigeminal nerve. So when you have muscle contractions that are affecting the muscles going to the innervated by the trigeminal nerve, you're going to also have impact in this muscle and impact in the ear. And this can also affect the eustachian tube. So here's the tensor tympani muscle, which is the trigeminal V3, excuse me, and this is the stapedius, which is seventh cranial nerve. Okay. Then there, in the back of the throat, we have the tensor villi palatini, which is supplied by the medial pterygoid nerve, which is a branch of V3. It's the only muscle in the palate not innervated by the pharyngeal plexus, which is formed by the vagal and glossopharyngeal nerves. So this is a muscle that's involved in swallowing. It tenses the soft palate, and by doing so assists the levator levi palatini in elevating the palate to occlude and prevent food from entering into the nasal pharynx during swallowing. A tense palate subsequently provides a stable platform for elevation of the pharynx during swallowing by the pharyngeal muscles. Since it's attached to the lateral collagenasis laminae of the auditory tube, also known as the eustachian tube, excuse me, it assists in opening or swallowing during yawning and pressure equalization. So spasm of this nerve we often see in TMD with the eustachian tube dysfunction. Okay, the vascular supply is the external carotid artery, which you know from your anatomy. Now let's look at dentistry in general. And I always wondered, like, what are the elements that make us think some of the things that we've developed philosophically in our practice? Well, you know, a lot of dentistry was making dentures. Fortunately, we don't see that. We've done a good job in prevention. We still have denture patients, but certainly not like when I graduated in 1975, so 45 years of practice. There were, you know, young people who were getting dentures. And the challenge in dentures is now you've lost all reference points. So how do you establish the vertical, the anterior-posterior relationships in a system that you've lost all relationship content? And so we developed articulations with modeling. Don't read this because you'll get a headache. But this is from the Journal of Prosthodontic Dentistry in the Academy of Prosthodontics. And this is the definition of centric relationship. There's 7 completely different relationships. And we know from those of you who have practiced for many years that the concept of pushing the jaw back as far as you can, that was, you know, the answer for solving centric relation problems. And then they had different philosophies. So you could, McCullen was push the jaw back as hard as you can, find that endpoint, get that nice hinge relationship so that you can do your restorative dentistry there. Then there was the more centric position. Roth, who was a surgeon and looking at internal derangements and stopping clicks, said that the condyle should be more centered. Dawson started to move it forward. Farrar, I'm sorry, was the surgeon who moved it further. And then Gelb said it should be as far, you know, far forward against the anterior slope of the eminence and of the posterior eminence. So I talked to a prosthodontic who just graduated school recently. I said, what did they teach you? And he said the upper anterior slope of the glenoid fossa. And I was glad to hear that. So that's what they're teaching now. And if we look at the disc itself, the most recent version of the glossary of prosthodontic terms defines centric CR as the position of the condyle within the intermediate zone of the articular disc interposed between the condylar head and the articular disc. And it's the most anterior superior position in that fossa. Goes along with the function of the internal pterygoid. So as you're closing, the interior pterygoid fires to stabilize the disc, the articular disc. Some people call it a meniscus. It's anatomically an articular disc against the posterior, the anterior-most slope of the posterior eminence. So we have, in this joint, we have basically function of 2 joint systems. We have the inferior surface, and if we look at the condylar surface, we have dense fibrous connective tissue covering the condylar surface. We have dense, which is in the blue here, we have dense fibrous connective tissue on the anterior only part of the glenoid fossa. This dense fibrous connective tissue is meant for the pressure of movement and the position of the articular disc, which is also dense fibrous connective tissue. So this dense fibrous connective tissue, we can see anatomically where that the posterior part of the glenoid fossa is not designed to take pressure from the condylar head. And if we look at slides, we can see how much the posterior band labeled A here is in the superior most portion of the glenoid fossa, and how this is against that anterior slope. And D here, how much of the interstitial tissue, which provides the synovial fluid and has rich nerve endings, is need of space. So you don't want to jam the jaw back into the ear, okay? You also have the discal malar ligament and sphenomandibular ligament that and the chordotympany nerve that all go through the tympanic fissure, which is at the posterior part of the joint system. So we have these basic 2 movements, rotation and translation. So the craniomandibular articulation is a complex joint. The hinge movement is called a gangliomoid joint. And the gliding movement is arthrodial joint, so it's a gangliomo-arthrodial joint with both the rotation and translation. Hence, the TMJ is a complex diarthrodal sliding gangliomoid and synovial joint which attaches to the mandible trapezius portion of the temporal bone of the cranium. You all knew that. So we have the rotation and translation. Okay, and here's a video.
This is a normal temporal mandibular joint. The disc is biconcave and it's located in the superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment. This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistent.
Yeah, so you can see how much space that posterior band of tissue in the articular disc needs, and how it slides forward, and how much space there is in the posterior that's needed. So let's look at temporomandibular disorders themselves. So you hear the expression TMJ, which is just the name of the joint. Temporomandibular disorders are a whole series of disorders of the whole system involved, not just the joint, but it's the muscles, the nerves, the whole structural system. So TMD encompasses many disorders of the mascatory muscle, myositis, muscle spasm, muscle contracture, myofascial pain syndrome, and the temporomandibular joint, internal derangement with or without reduction, and degenerative joint diseases. The American Academy of Orofacial Pain defined TMD as a collective term embracing a number of clinical problems involved in the mascatory muscle system. So we have muscle disorders. We have myofascial pain, myositis, and myospasms. And then we have joint disorders, inflammatory conditions, internal derangements, disc sticking, which was just degenerative, disarticulations, displacements, and osteoarthritis. So the age distribution here, this is male, female, and the age group, you can see that you have the 25 to 45 years old. As you get older, they kind of adapt, but certainly these patients have fun, but have problems. But look at the discrepancy between female and male. And I want to go over that because when I first started in this field, there was an ugly term called histrionic, the TMJ. Physicians ignore this, and they don't appreciate it. It's kind of like the jaw isn't part of the body. You see this with medical insurance. You see this in the field. It took a long time for ear, nose, and throat doctors to appreciate that when a patient comes in with ear pain and they don't have anything wrong with their ear, they look at it and it looks fine, that now they refer for TMD. And I get referrals all the time with the ENT community. But this wasn't always the case. But they just basically said, oh, it's just women complaining, which is a pretty ugly thing. But now science revealed a reason for that, a very important reason. So the pain receptors are estrogenic. So we have estrogen receptor alpha polymorphisms and predisposition to TMJ disorder. In this study, it suggests that a polymorphism in the estrogen receptor may increase the risk of women developing TMJ disorder. This finding may elucidate to inter-individual differences in the contribution of estrogen to TMD. Genetic influences on TMJ predisposition and may serve as a basis for future treatment. So this estrogen receptor on the female's mast cell, this receptor genetically coded to provide the female with an inflammatory enhancement is absent in men. So we might have the same condition as a woman, but she's going to experience the pain in this particular area to a much greater degree than a man will because of this estrogen receptor. So one of the substances released by the mast cell is NGF, nerve growth factor, which stimulates the production of substance P and vasoactive interstitial polypeptide. As a result, female will get more chemicals, more inflammation, more pain, and more swelling from the same stimulus as will the male. Okay? Live and learn. So derangements of the temporomandibular joint are divided into internal. I remember when we took anatomy in school, whenever there's a muscle that's internal, there's going to be an external. When there's a superior, there's going to be an inferior. So if we're going to have an internal derangement, we're also going to have an external derangement. So let's look first at the internal derangements of the joint. And we divide this as with reduction and without reduction. So with reduction is there's a road bump. This is the way I describe it to patients. That click, that pathognomonic click that you hear, that you can, you know, some patients manage and live with it, and other patients it drives them crazy. But this bump that you feel is the popping of the condylar head over the posterior band of the articular disc. So once it pops, it's actually reduced in place. So that's why they say with reduction. And the rest of the opening cycle, it's actually in right place. And the problem is in closing that it again slips off the disc. Now the slipping off is easier. They might have what we call a reciprocal click, which is some sound as it goes off, but often it's silent. And then once it's slipped off, the next opening cycle, it has to pop back on. So this is what the disc out of place, the posterior band, the condylar head behind that. And as you come forward, you pop over the disc and reduce it into the proper position of the disc between the two bones. This is what it looks like in an MRI. Now, MRI doesn't show up this tissue very well because the MRI shows water. And the dense fibrous connective tissue disc has very little water. So basically what it shows up is a black hole, a black space, and you see the darkness in front of the condyle here. And so the clinical signs of the internal derangement with reduction is the click. Now, the internal derangement without reduction is now the disc becomes a road block. And what you see is patients will come in and they say, oh, my click got better. It's fixed now, but I can't open my jaw. And what I have to explain to them, the whole anatomical situation there is no, it's actually more severe now. And the problem is that it's not able to go over. It's that disc has become from a road bump to a road block now. So this is what it would look like. And in trying to translate, there's no click and a limited opening. So here's an MRI. You see the dark space in the disc, and the left is closed and the right is opening, and you can see how the disc just bunches up there, and there's no way to translate and reduce. So you have a limited opening. The treatment for this is what I tell patients. There's two ways we're going to manage it. I'm always conservative with my treatment. I'm conservative with my giving them pain medication, which we're going to have the opiate talk after this. I treat pain all day long, and my philosophy is if I can't fix the problem, there's a lot of good prescribers out there, and I'm not going to give them, because I actually rather see what their true symptoms are. So there's two outcomes to a internal derangement without reduction, is to recapture the disc and have it start to be able to become a click again, but move fully, or to kind of start pushing the disc out of the way. And what happens is that the retrodiscal tissue that's now between the condylar head and the glenoid fossa, with the disc out in front, condenses into dense fibrous connective tissue. So basically it becomes what we call a pseudodisc, and you can stretch the jaw through movement and exercise and regain the movement and have it be a functioning, pretty normal joint without pain by doing that. So those are the two ways that I've been working with an internal derangement without reduction. So here's a schematic of the disc derangement and opening, and you can see that the dark lines showing that it just bunches up in front. And you usually won't get this much translation. You'll open about anywhere from 20 to 28 millimeters interincisal opening. Then we have external derangements, which we can talk about as far as the muscle. So there, when we have this whole sensitive system that, you know, we express our emotions, we speak through our mouth, we make love through our mouth, we eat through our mouth, we breathe, you know, all these important functions that are going on all the time. And so if we have interference, constricted blood supply, it's going to cause inflammation, chemical changes going to affect the muscles, and the muscles can become sore, dysfunctional, and the important balance between the muscles can be thrown off, leading to pain. Okay, and the interesting thing about muscle pain, and this is part of what I love about this field, is it makes you have to be a detective. And so where a person's telling you the pain is not often the source of the dysfunction or even the source of the muscle that's triggering the pain. So we take here the sternocleidomastoid muscle, and there's this thing called referral of pain. So all the X's are where there might be trigger points, which are sources of pain sensation, but the red is the areas that you might feel that pain. So the deep sternocleidomastoid, the clavicular division, will actually cause a frontal headache on the contralateral side. So somebody could come in and say, I'm having headaches on my right forehead, and they're actually having a trigger point in their left sternocleidomastoid muscle. So we have to figure this all out and in order to treat the right source of the pain. And when you do, you get an effective response. So I've seen patients over the years that come in with multiple root canals. I've seen full mouth root canals. I don't know how the patient allowed it or the doctor didn't stop at some point. But we can get from the temporalis, we can get triggering of pain into the teeth. So dental pain could be coming from the muscles. So when Stanford medical students come to my office and spend a half day with me as they do their internal medicine rotation. And I give a lot of lectures to physicians. And when I do, I like to get physicians to start looking at the mouth and looking at teeth. But they're not going to look at teeth from the standpoint of, gee, I'm going to diagnose cavities and I don't want them and I don't expect them to do that. But I want them to start to see teeth as an orthopedic support system of the temporomandibular joint. All right, so teeth, the occlusion creates the spatial relationship in the jaw joint. So it's probably the only joint system in the body that its position and function in its joint system is determined by something that's far away from it, teeth. Okay, so we know that a lot of manipulation of orthodontics, of growth and development affect teeth, affect, you know, class 2, deep bites are kind of the worst for airway and for TMD. And so we want to think of the support, the orthopedic support of teeth. Are teeth tall enough to support compression from the joint? Are they the position of the jaw anterior enough to keep it on that anterior slope? So we, again, looking at the spacing here, you see the posterior band, which is the most superior, the 12 o'clock position here, and the pressure, the gray area, I can't use this pointer here, but the dense fibrous connective tissue over the condylar head, the dense fibrous connective tissue over the eminence of the glenoid fossa, and the loose tissue with blood and synovial fluid production in the back. This is the spacing that we need to relieve pressure in this system. And when we don't have this and where the jaw should stop its movement, it's basically like having a door that bangs into the wall, and banging into that posterior wall is going to hit all that structure back there. And it's going to fire nerves, and it's going to cause pressure and inflammation that the body can start remodeling, send osteoclasts there and have remodeling of the bone and degenerative process. So it's the body's attempt to heal the pressure is to eat away bone. And so this pressure here. The other thing that I want physicians and you guys to think of teeth as proprioceptors. And proprioception is a very incredibly important thing to your function that you don't even appreciate. Again, looking at that homunculus, The brain is a giant hand and mouth. And this is maybe babies. I have a 6-month-old grandchild, and everything that he's loving grabbing things now. He's getting used to his hands, and he wants to bring everything to his mouth. So they're working together. But we think of teeth now. One of the questions I love to ask dentists is, why is there so much damn nerve tissue in the center of a tooth? And very rarely do I get an answer to this. But that nerve tissue is a proprioceptor. It's feeling vibration of touch on the enamel through the vibration inside the tooth. All right, and that's why it's there. It's estimated about 47% of the proprioception is inside the tooth, and the rest is in the periodontal ligament. So we know that after a root canal, you put on a crown, and a patient can still tell you that the tooth is high or that there's pressure somewhere, because you still have the periodontal ligament with its vast proprioceptive information about the pressures on the teeth. All right. So the periodontal ligament provides stability of the dental socket. The principal fibers of the periodontal ligament form a strong fibrous union between the root cementum and the bone. It provides cushion. It's a shock absorber. And we know this very well through implants. So I went on the Glidewell website. I'm not sure if I have it in this talk, but they advise you to make the crown for an implant a little lower than the occlusal plane, because what will happen on the teeth that have a periodontal ligament, it's like walking on the carpet. It mushes down, and the tooth microscopically has a give to it. Think about the difference of walking on a wood floor all day and walking on a tile floor all day. So the implant is like walking on a tile floor. There's no give. The tooth is like walking on a wood floor, which looks solid. You don't see it, but there's enough microscopic give that it takes off a lot of pressure from your joints. So the cushion, the light forces are cushioned mainly by the intravascular fluid that is forced out. Moderate forces are absorbed by the extravascular tissue fluid that's flowed out and the periodontal ligament and adjacent spaces. And the heavier forces are taken up by the principal fibers of the periodontal ligament. There's also, again, a lot of sensory proprioception. Okay. In the Journal of Orofacial Pain, I remember in school that I loved anatomy and histology, and I remember that nerves were stained with silver impregnation stain. Well, it turns out that this stain is it's not very sensitive. So we were missing a lot of the nerve endings and nerve systems in the body when we did histological studies. But now they have new markers. You don't have to remember this, but just know that there's these new sensitive markers that show up this tissue now. And when they looked at the joint, these results give new support to extensive rich innervation of the human temporomandibular joint, capsule, and disc. So basically, the joint itself is loaded with proprioceptors. And if you have pressure and compression and strain in there, it's going to fire these proprioceptors, signaling reactions in the nerves and in the muscles. So let's look at head posture in relationship to the jaw. So very much integrated. When I was just on one of the online groups that were talking about sleep apnea and TMD problems. And when there's some studies that show that 50% of the people, if you looked at them, TMD patients, 50% of them have airway problems. If you look at people with airway problems, 50% of them have TMD problems. So they're basically, it's one system that can affect the joint system, or it can or the airway. So head posture, the cervical vertebral alignment is in function. This article shows when you have this posterior compression, think of this as not just taking the condyle back, it's taking the whole mandible back, but it's also taking the throat back. And so what you see in these patients is you see them compensating to keep their airway open, because that's the most important part of your brain. And the way it does it is by forward head posture. So if you look at your patients with deep bites, posterior, class 2, you'll also notice that invariably they have this forward head posture. in the old times with TMD issues, the patients with head and neck pain, we'd send to the physical therapist, your head postures forward, and they'd work on them and they never get any results. Why? Because this is the easy area this makes it possible to breathe with less resistance, and the brain's going to position you to breathe. Okay, so we see this posturing affecting the muscles of the neck and back coming from the jaw and airway, leading to pain. So this is a wonderful patient who had, during those years, you would never say she's histrionic. She's a sweet, lovely girl, happy, engaged. She had severe head and neck and back pain. And what we did is we just freed up her jaw with a splint, let her jaw come forward on its own, not bringing it forward. And immediately she straightened up. Her head, neck, and back pain went away. So there's something called a Romberg sign, which is a neurologic test. And it's a test of the body's sense of positioning, proprioception, which requires a healthy function of the dorsal columns of the spine. So what it is basically having the patient stand up, put their arms out in front of them or fold their arms in front of them and close their eyes with their feet together. And if they can't be stable, they drift to one side or they lose balance. This is because we keep our balance with our eyes. The vestibular system needs a reference point. So when you're looking, you have all these reference points around you. You have the walls, you have in a restaurant, you have the table in front of you. Again, when that table tips, it drives you crazy because that reference point is moving. But when you're standing, that information comes from the feet all the way up the dorsal column, which is continuous and intermeshed with the sending trigeminal nerve. So basically a trigeminal nerve could be seen as the upper part of this dorsal column receiving information. So what happens is there's convergence of these nerves together with the trigeminal nerve. So again, the table of the restaurant tipping. So this is a patient who came in, he was in a car accident on the freeway. He had been seen by the neurologist, ENT, you name it, and he couldn't keep his balance. And so we brought him in, and this is a Romberg test, and you see him falling backwards. His wife, as soon as his wife touches him, that's the reference point, he's stable, and she lets him go, and he falls. And notice he's falling in one direction, back to the right. He can't keep himself stable. And all we did is we put tongue blades in his mouth to take pressure off the trigeminal nerves in the jaw joint, which basically quieted those nerves and allowed the information to come up. And instantly,
take your hand off.
He was tired. Now in this video, what I'm doing is I'm having him hold his hand on a cabinet, just touching his finger, which is the reference point. As soon as he lets that go, he loses the reference point.
Okay, now
so
close your eyes and put your hand back.
So I now have the Stanford Balance
Just
Center
touch your
looking
one
for
finger
this
to the
because
wall.
they always knew that
That's your
cervical
reference
problems and
point. Now you're
thoracic
balanced.
problems cause problems, but they never thought of the jaw. Over and over again, I see this where people are ignoring the jaw as if it doesn't belong in the system. So we want to look, we have cone beam CTs where we can see the spacing, we can see the pressures. And so this is the patient after a splint in his mouth, opening up those spaces. We didn't open it up much. You can see the closing of that joint as opposed to the opening of that. That was enough space to relieve the pressure on those nerves. So one of the diagnoses of TMG is dizziness. 40% of patients report vague dizziness and imbalance. This would be the proprioceptive imbalance. Fullness of the ear affecting the eustachian tube and ringing of the ear. I treat a lot of patients with tinnitus that were successful in relieving this with the relieving pressure of the jaw and the ear and doing some physical medicine to relieve the pressure that's built up in the cranial system. So there's a condition called temporal arteritis, which is a very severe, significant condition, which is symptoms of double vision, sudden permanent loss of vision in one eye, throbbing headache, which is usually in the temples, fatigue, weakness, loss of appetite, jaw pain, unilateral, unintentional weight loss, shoulder, hip pain. So basically it's this conglomerate of pain. And when a patient comes in with a headache, the concern is that temporal arteritis can lead to some very serious problems. And the way to do this is to do a biopsy of the nerve. of the temporal artery, and to look for signs of inflammation here. So it's a difficult one, and the physicians kind of go to this because they're very concerned. If this is something they missed, it would be a very bad thing, because it can lead to a lot of health issues. And then we have acoustic neuroma, which is, again, discerning your pain patients, patient from a simple headache, a myogenic pain, to acoustic neuroma or temporal arteritis. So again, problems of balance, vertigo, facial numbness, tingling, facial weakness, Bell's palsy-like symptoms, taste changes, difficult swallowing, headaches, clumsiness, unsteadiness, and confusion. Treatment for acoustic neuroma may include regular monitoring, radiation, or surgical removal. So this is a picture of an acoustic neuroma. And when they go in there to surgically remove it, they often damage the facial nerve, and the patient is left with Bell's palsy from the procedure, which is very common. So therapy for TMDs. I want to do, we divide it into phase 1, which is always reversible care. So a splint or orthotic, which I use a flat plane muscle neutralizing orthotic, means it's just a flat plane. The only contact I have is in the lingual cusp of the first molar on the flat plane, and it helps make it easier for proprioceptive. It eliminates the chance of banging into other teeth, which sets off nerves. It just simplifies the splint therapy. Physical medicine, muscle therapy with physical therapists. I do osteopathic manipulation myself. Stress management, mindfulness meditation, which I teach the mindfulness program at Stanford, and do a lot of one-on-one with my patients as I'm working with them, and biofeedback. Trigger point injections to treat the triggering of the areas that are triggering the pain, the referred pain, and prescriptions, non-steroidal prescriptions. I don't ever think it's serious enough for opiates. So this is what I see a lot, and this is kind of the old therapy. And patients come in, and I was recently had an accident where I tore my. I'm in a cast right now. I tore my quad tendon to my patella and had surgery last Friday on it. And I was in the hospital, and the thing was digging in. The cast I had was digging into my Achilles tendon and my heel. And I tried to get the nurses to put a pad underneath of it. And it's like they wouldn't listen to me. And there was a young nurse there, and I finally got him to do it right. And I said, I'm going to give you one old man's recommendation for a young, a practitioner. I said, listen to the patient. I said, because 99% of the time when I listen to the patient and I don't see anything, finally when I find it, figure it out, they were right. And when a patient tells you that they feel tight from a splint, or it's putting pressure, or it doesn't feel relief, they're right. And I see this all the time where the splints that are made to either retrude the jaw or hold it back, you're opening vertical, but you're not allowing the pressure to relieve from between the jaw and the ear. So these splints, be careful with if you're going to make an upper splint. This is a physician that was in this case.
What symptoms were you having when you were in this one, this upper splint?
I had 2 episodes of sudden pain in my jaw and inability to open completely.
Okay. And then when you switched to the lower splint?
Within hours, I started in the morning. Within hours that night, I had ability to open my jaw fully, and the pain went away the next day.
So listen to your patients. These bite ramps, getting a splint I don't think a splint needs cuspid rise or anterior disclusion. That's not the purpose, because it tends to hold the jaw back. I want to free it up. I don't bring it forward. I free it up to come forward on its own. So there's a statement of the American College of Prosthodontics that talking about the role of oral devices in managing sleep disorder breathing. The effect of the use of a night guard for sleep breathing on OSA remains uncertain. However, increasing the occlusal vertical dimension with a maxillary night guard without mandibular protrusion or with mandibular retrusion has been found to aggravate obstructive sleep apnea in some patients. Practitioners should screen patients for OSA prior to fabricating maxillary night guards that increase vertical dimension without mandibular protrusion. Prosthodontists must screen patients for OSA during treatment planning stages and beware of other maladies. I just say use a lower flat plane splint and you don't have to worry about that. So 39 to 47% of sleep disorder patients demonstrate greater reduction in motor activity with mandibular advancement splints than conventional occlusal splints. So we have the NTI systems, which stands for nociceptive trigenital inhibition, which does free up the jaw and does allow the jaw to come forward. So this is one way to do this that is respectful of that. And then I prefer to use a mandibular splint. It's a lot easier for the patient to use. Patients don't see it. Notice in the front, I just bring it up to the incisal edge. And people might say, well, you could get extrusion of the anterior teeth. Well, no, it's cupping the cingula and it's keeping any extrusion. Plus, my goal is to get them managed so that they're just wearing this at night. It's not a 24-hour period usage. So we're doing therapies for their muscles, and the goal is can they get off the splint completely, or can they just use it at night for enough time to release? So here's a patient that patient that just spoke with a deep bite. You can see that basically the maxilla is holding the jaw back. And when it does that, it takes the airway. So nature's NTI appliance is the tongue. So the tongue, proper tongue function is supposed to be a spine basically holding the jaw in space. So we've heard the term of freeway space. You know, it used to be if you violated freeway space, that somehow the patient would die. Now we know that that's not true. It was just an ism. But the tongue being up against the palate and being strong stabilizes the mandible in space and reciprocally inhibits the contraction of the muscles. So particularly in bruxism cases, you want to have good tongue function, which is very hard to do. We know that patients with tongue thrust, orthodontic cases, that it affects the treatment. People with speech, kids with speech problems, it's very hard, to change that. So I developed a system to do that, and we use that with speech patients. There's a speech pathologist in the area that has her young kids that she's working with, and we use this in the Oasis sleep system as one of the actions. We also use that in splint therapy to get the back of the tongue up to the palate. So it's these pads on the inside that look like they might be sticking into tissue, but they actually go into a space at the root of the tongue. And it makes it so you can't take a shortcut and be lazy with your throat. And it gets your tongue, your back of your tongue sucked up to your palate. So if you right now take your tongue and put it to your palate and kind of suck in your throat and create a vacuum in your throat and hold that vacuum. And while I'm talking to you, keep on holding that vacuum. And notice as you're breathing through your nose, you can breathe behind that freely. So what's happened is your tongue has gone up to the palate, the back of the soft palate has cupped the tongue and create a seal between the mouth and the throat. This is in orthodontics, it's called an oral seal. This is the way we're supposed to be functioning. And once the tongue is up there and gets strong, then that helps these clenchers and bruxers. So this is a kid that had this therapy.
This is 60.
Okay. 5, 10, 15, 20, 25, 30, 35, 40, 45, 50, 55, 60.
This is him about 3 months later.
61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
So we can see that this is a way that I worked, and I had a poor tongue swallowing. I worked for 35 years with myofunctional therapists, and I couldn't change my throat. When I did this, within a couple of weeks, my tongue is always at the roof of my mouth. I'm so happy that I'm in this field. because it's helped me immensely. So we limit the time of the splint usage. I tell my patients going to wear it day and night, except for when you eat, for about 6 to 8 weeks. And then we're going to see if you can stop using it and go to just at night. If they have a return of symptoms due to lack of resilience of the joint muscle system or improper orthopedics of the craniomandibular system, they may benefit from phase 2 treatments, which can be orthodontics, could be restorative, something to give them the orthopedic support that they need. So in conclusion, what I want to talk about, what I want to say is that I hope that you'll start to see this incredible sensitive system that you work with and how many different ways that this can affect overall health. We're the ones that guide growth and development. A study just came out from Stanford. The book, I'm forgetting what it's called. What's her name? Orthodontist in our area. Semplowski at Stanford. Anyway, they looked at the changes in the facial growth, and it's because of the foods. It's because it's not just a natural evolutionary thing. It's because of the environmental growth factors. So nature's orthodontics are the tongue at the roof of the mouth, pushing the palate, expanding the arch, the lips, the orbicularis oris, and nasal breathing. And if you see any of one of those compromised, you see changes in growth. So you want to catch the kids as young as you can, with poor speech, with poor tongue function. Help expansion of orthodontics can be the best friend of the airway and the temporomandibular joint support. So I'd like you to, you know, to have a sense that you are the doctor of the craniofacial system, and to use all the knowledge and wisdom that you have to benefit your patients. Thank you.
All right, thank you very much, Dr. Abramson. That was excellent. Our next presenter is Bruce Bohannan, DDS MD. Dr. Bohannan has been practicing oral and maxillofacial surgery since 1998. He's an honor graduate of UOP Dental School and graduated with distinction from the University of Missouri, where he received his medical degree and completed his residency. He became board certified in oral and maxillofacial surgery in 2000. He maintains private practices in Burlingame and San Jose. So please welcome Dr. Bruce Bohannan.
Okay, just trying to get my screen share. Can you guys see my screen?
Yeah, we can see it.
Okay, great. All right, so my lecture tonight is about the opioid crisis we're having here in America. And we've seen a lot of the changes that we've been identified by our government in trying to regulate opioids, which basically didn't do a lot. It helped curb things, but then the pandemic hit and we are right back into a super crisis again.
Through poison-tainted veins, I feel a warmth that soothes but is surreal. It's funny how we became acquainted. He made me quiver. I almost fainted. He seemed so cool, so calm and sweet. He swept me off my virgin feet. We fell in love, or so I thought. My soul almighty love is what he sought. He hid his identity with a comforting mask, only to disguise his horrid task. With every kiss he sucked me dry. His soft caress was all a lie. He came inside me, just a little prick. It made me lightheaded and a little bit sick. He abused me raw till my arms were sore. My cheekbones were visible, but I craved him more. He made me chase him and steal, lie and cheat. He wore down my body until I fell in defeat. He cackled at my pain, his full destruction of me, but I am too dope sick that this I can't see. Still I begged and I pleaded for him to return, an ongoing cycle, why didn't I learn? So at night I fell asleep with him by my side, but woke up with no one. He promised, he lied. So today again I make it my priority, my chore, to find him in vain and again be his whore. His passion I want, I crave and I need. The rush that I get, fill that indeed. I may never make it, but to you I dare say, if he should strut by, look the other way. He'll charm you and flirt with his deadly advances. He'll shower you with false promises and convincing romances. He could come upon you any old day with a twinkle in his eye and his look that could sway. This is your warning, so darling, take heed. What he does offer you, you surely don't need. A handful of problems, a life that is dark. In no time he'll have you, and your gravestone he'll mark.
So a poem written by Natalie Krabari to her younger sister just before she overdosed a few weeks later. Tonight, I want to talk to you about what is an opioids, where do they come from, what are the alarming statistics that we're dealing with, why are adolescents so vulnerable to addiction, what can be done, the scientific evidence that supports the most vulnerable population, and why their brains are such a receptacle for this easy addiction. Understand the scope of the opioid crisis in America, understand a developing brain, understand the steps that we can take to help reduce narcotic use, why awareness and education is the first and most critical step in controlling the epidemic, and at the end of the course, practitioners should understand the broad nature of the opioid crisis and why it is an epidemic, and recognize signs and symptoms of narcotic abuse. They should understand why these drugs have such an abuse potential and what steps they can take to do their part in controlling the crisis. So opioids can be pills, it can be injected, it can be snorted, it can be taken many different ways. So opioids are a type of pain medicine that is man-made, or it can be naturally occurring like morphine or heroin. Where do they come from? Well, it comes from the opium poppy. And it comes from 3 places that have the perfect climate to grow this, this flower, which is in Afghanistan called the Golden Crescent, and Southeast Asia called the Golden Triangle, and Jalisco, Mexico, and to a lesser extent, Colombia is now producing quite a bit of opium. So Afghanistan produces about 80% of the world's opium. It's worth over $4 billion in export until 2017, where they increased production by 87%. Opium production up 87% in 2017 to 9,000 tons. That's 4,200 tons more than 2016. The Helmand province alone increased by 63,700 hectares. And a hectare is an area which is 10,000 square meters, or about 2.471 acres. So if we go to the Golden Triangle, about the same size of an area, but they produce far less, but it's still significant. And in Mexico, the reason they're not competing very well with Afghanistan and Southeast Asia is their quality of their drug is quite poor. It's called black tar, and black tar is about 75% contaminated due to poor processing. It's far less expensive than the Eastern white powder. The tar, when injected, acts like a sticky tar. It occludes veins, and you can see the person on the right here with all the pock marks. That's actually skin necrosis that causes scarring because of the toxicity of the drug that they're injecting. And you can see how desperate they get where they inject drugs, or they have friends inject drugs. And then of course it has to get from the source to wherever it's going, and there's common routes that the DEA says where things come to the United States. So the world's deadliest drug is a Russian narcotic. Luckily, it's not found its way over here very much, but it's pretty significant. So it's called a crocodile, and about 20% of the world's supply of heroin goes through Russia. We have about 30%. So they're a little bit behind us, but what's different in their realm is about 90% of the narcotic abuse is with heroin, where most of our people now are actually using prescription drugs. About 60% in the country now are on prescription drugs and not heroin. So influx of opium from the Golden Crescent province, it's not far to go from Afghanistan to Russia, but crocodile is much cheaper and than the high quality imported heroin. It's about 3 times more potent, costs about 1/10. Can be made in your kitchen. It's a synthetic opioid. It's made with wonderful stuff. You take some codeine-based headache pills, you mix it with some gasoline, iodine, hydrochloric acid, and red phosphorus, and some paint thinner and alcohol, and then you shoot it into your vein. Sounds great. And what it does is it causes skin death and necrosis if it goes outside the vein. And why it's termed the deadliest drug is the average time from beginning of use to death is about 6 months to 2 years. Desmomorphine is another additive that the Russians add to their, this isn't the homemade version, this is the distributed version. And it's highly addictive. As a matter of fact, it was taken off the market. It was made in the US and supplied in the Swiss by Roche, and it was just too addictive. It was a very addictive narcotic, so they took it off, but the Russians are using it so it quickly hooks the user. How do I minimize this? Miss a vein and you get necrosis and gangrene is rapid. Amputations are frequent in these patients, and you can see up here, you can see the large area of skin necrosis on this lady's foot, on this lady's leg. You can see this part up here. The jawline is particularly sensitive to the medicine, and here on this far side, you just have exposed bone. And the withdrawal is coined inhuman to endure. And this is where people often have suicide and, because of how difficult it is to get off the drug. And it can cause severe illness and pain for up to 10 days. And crocodile withdrawal symptoms can last over a month. So opium, morphine, and heroin, they are the naturally occurring types. They come from the poppy, like we mentioned. And then you have synthetic opioids, which are made entirely in a lab, like fentanyl and Demerol and methadone, and semi-synthetic opioids, which are synthesized from naturally occurring opium products such as morphine and codeine. And they include the heroin, the oxycodone, hydrocodone, and hydromorphone. And teens obtain most narcotics from family, friends, their medicine cabinets, nursing homes, hospitals, doctors, and of course now the internet. And they have some lovely names: antifreeze, H-chunk, big H, black olives, black tar, black ant hazel, capital H, chocolate, DOA, salt smack, horse skag, brown sugar, wings, Tootsie Rolls. And when you mix it with cocaine, it's called speedball. And that's only the scratching the surface of all the different names I found. So the interesting fact about heroin is it was manufactured originally by the Bayer Corporation in the 1890s for cough suppressant and pain relief. It also treated asthma, bronchitis, and tuberculosis, and its generic name was diacetylmorphine. Heroin was the brand name. The German researchers noted people who took it said it made them feel heroisch, or German for heroic. So apparently when you do heroin, you are heroic. This is where the brand name came from. Bayer stopped producing the drug in 1913. However, Great Britain still uses heroin, the legal form of heroin, and accounts for 95% of the world's legal heroin use. So how is heroin used? Like we mentioned earlier, the three most common ways are injected, snorted, and smoked, but it also can be what's called plugged, and you can figure out where that's going. So, and then we have some common prescriptions: Norco, Vicodin, Loratab, Oxycontin, morphine, fentanyl, codeine, methadone, oxymorphone, and hydromorphone, Dilaudid are the common ones. So they're an essential medication for pain relief. Other uses obviously are in anesthesia. I use these drugs every day in my practice. They're also used for cough suppression and treatment for diarrhea. Toxic effects, most common, are lethargy, respiratory depression, overdose, and death. So in addition to reducing pain, we have some issues that the drugs cause: drowsiness and sedation, mental confusion, nausea, vomiting, constipation, pinpoint pupils, slow pulse and breathing, depressed body temperature, blood pressure, and of course, if you use too much, you get overdose and death. So what is fentanyl? It's known as China White. Its other names are Apache, Crazy One, Butter, Jacket, Fent, and Fentanyl. It's a powerful synthetic pain medicine. It's somewhere between 50 and 100 times more potent than morphine. It's used to treat severe pain, and it's often related to surgery. It's available as an injection, patch, lozenge, or lollipop, which you can see here in the pictures. It's clandestine laboratories are playing a bigger role in the epidemic because they're making this stuff and lacing their products with it. Why is it dangerous? Well, it has an uncertain purity, and if you don't mix it right, you can actually make it much more potent than you think it is. It can cause breathing to stop abruptly, and death happens quickly due to asphyxia or anoxia. It's often added, like I mentioned, to poor quality heroin and sold as OxyContin, which it's not. Many new synthetics are based off fentanyl that we use in anesthesia: afentanyl, sufentanil, and remifentanil. The advantage of like remifentanil is it only lasts 2 or 3 minutes. So it hits you hard, but then it's gone. So in short procedures, that's superior to fentanyl, which hangs around for 20 to 40 minutes. So fentanyl is a synthetic opioid. It's especially dangerous because it's often added to heroin, like we said, and the pills look like real prescription drugs, and they're really not. And it's, again, up to 50, sometimes 100 times more potent than morphine, and 30 to 50 times more deadly than heroin. An equivalent amount of a lethal amount is just a few grains of table salt. And then if we look in a drug called carfentanil, which was used to tranquilize very large animals, some drug dealers got a hold of this and decided to lace their drugs with this. And you literally only need a couple of grains of this stuff to kill you. And this is a family that was a picture that was taken. They thought they were going to get a little hit of heroin, and unfortunately had carfentanil, and they died very shortly. And there's the child awake in the back with the policeman reaching in. And it's one of the most powerful opioids available. It's 10,000 times more potent than morphine and 100 times more potent than fentanyl. And it's linked to literally thousands of overdose deaths across the country. And again, labs are mixing it with their product, and it's often manufactured now in China and imported to the US. So how did we get there? There's kind of a picture down there, and it's a little misleading. So the fentanyl is about right on the left. The carfentanil, it's literally about 1/5 of that is all you would need to have a lethal dose. And you can see the wonderful effects of popping narcotics under your skin. So how did we get there? Well, you know, chronic pain was identified by many medical groups. It was undertreated. They believed it was undertreated in the 90s, and numerous medical societies endorsed the increased use of pain medicine, including the American Academy of Pain Medicine, the American Pain Society, the Pain Society, and the American Geriatric Society. So one of the most commonly cited statistic was by Porter in the New England Journal of Medicine in the title Addiction Rare in Patients Treated with Narcotics. They said they only recognized 4 cases of addiction among almost 12,000 patients treated with opioids. And if you do a Google Scholar search, it's cited in 693 other articles that say that there is not much addiction chances with the use of narcotics. What do you guys think about that? I think they may have got that one wrong. So a few words about OxyContin. OxyContin was released in 1995. It's a controlled release substance. So they felt because it's controlled release, you don't get that surge of drug in the body. And so that decreased euphoria. And they market it as non-addictive, okay? I remember when my wisdom teeth were removed, I got a prescription for Vicodin for 50 tablets with 3 refills. That's back when you could refill a Schedule III drug. Now Vicodin is Schedule II. In a residency, it was typical for the attendings to tell us, oh, just prescribe them 30 Vicodin with 2 refills. That way they're not gonna bother you, okay? So OxyContin had a very successful marketing tactic. They went out, they got reps, they said, hey, this is the new wonder drug, controls pain, there's no addiction, and it's very safe to use. And in 1996, you see right off the bat, remember this came out in 95, right off the bat, they did almost 45 million in sales. And then by 2002, they did over 1.5 billion in sales. So I had to figure out a way to get one of my favorite actors in, that's The Rock. So anyway, a lot of these companies over time, and especially in the last few years, have been taken to the carpet by our government, saying that you used deceptive marketing practices, not only to the doctors, but to the patients. And of course, the class action lawsuits were brought forth and several of the companies are now out of business. So why do some drugs lead to abuse and dependence? Because it's the effect on the brain that they have. And it's the alteration of brain chemistry. Many drugs have no abuse potential: aspirin, antibiotics, high blood pressure medicine. Others can lead to abuse and dependence, including opioids and sedatives, just to name a few. So opioids work by binding to the brain's opioids receptors, and they block the pain in the brain and in the spinal cord and at the site of not at the site of injury. Because of this, opioids can create a sense of euphoria. If taken over a period of time, opioids can require larger and larger doses in order to work and give you that sense of euphoria. This makes opioids extremely habit-forming and ultimately addictive. So let's just look at the basic, really simple schematic of a nerve cell. So if this was a natural endorphin, you have your presynaptic, you have your cleft, and your postsynaptic nerve fiber, okay? So you have some stimulus that makes the presynaptic fiber release its chemical into the cleft and binds to receptors on the postsynapse area, okay? And that's typically how it works. And then there's a feedback system, and I'm not gonna get into all that, but what ends up happening is if you add exogenous, so you have the endogenous form that's here, and the exogenous form, let's say heroin, going to a mu receptor, an opioid receptor, your body's gonna go, well, I don't need to make as much of my own because I've got all this supply here, and my negative feedback system is telling me I don't need as much because I've got this extra that's here. And lo and behold, that starts to happen. The heroin comes in, your body doesn't release as more. Doesn't need to make it until you get to the point where your body's just simply going to make very little, if any, of its own endogenous chemical and rely totally on the exogenous chemical. So think of it like a thermostat, okay? So if I set my thermostat at 71, it's reading the temperature in my house at 71, and if it gets below that, it's gonna fire off the heater to heat the house. But if I've got a space heater right next to the thermostat, that's giving this a false sense of reading. So it may be 71 in this room, but 60 around the house, but this doesn't know any better because it's being falsely elevated by that guy. So what happens to endorphins and heroin over time? Well, it changes our brain chemistry. And so in the brain development of the teens, why are the teens or younger children more vulnerable to addiction? Well, the brain development and maturation continues well into our early 20s. And so the area of the brain to develop in the early teen years that helps regulate our risk-taking, our sensation-seeking, and an adrenaline rush, that ability to control that is weakened or not just simply not developed in the adolescent brain. So in the later years, for most of us, I still think some of us never developed this, but anyway, we get some inhibitory functions of our brain that help regulate emotion, help control impulses, consider the consequences of what you do before you act, and the judgment and decision making are hopefully improved, like I said, in most adults. So the brain development in teens, based on scientific evidence, teen brains make you more susceptible to opioid addiction than older adults. It's not the teens' fault that they're more susceptible, but some teens have more susceptibility. Certain brains are wired differently. There's certain neurochemical differences between the brain, but they simply don't have the development to regulate risk-taking, and they seek rewards so much easier than that of an adult. So it's important to reduce exposure to opioids, especially in the adolescent brain. So if we look at it further, here are some PET scans of brains that are kind of interesting. What you're looking for is the purple. This is the maturation or increasing of gray matter as the young brain develops from 5 to 20. And we want to look at the prefrontal cortex because that's the last to develop, and that matures through the mid-20s. And that gives us inhibition and self-control and thoughtful decisions, makes us wary and cautious, so that when we're standing on that roof jumping into a pool, if we're an adult, we go, wow, I could crack my head open and die, where the young kid doesn't think that. They think, oh, I just jump in the pool. It's perfectly safe. No big deal. Jump off. No big deal. Right? Well, as we get older, we do have some of that inhibition and self-control, at least most of us. And then we have the nucleus accumbens, and that regulates reward seeking. It's full of dopamine, and it's a process of motivation and pleasure. And then we have the amygdala, which develops emotions. And then we have the nucleus accumbens and the amygdala develop earlier than the prefrontal cortex. So we have all these things that are emotionally driven, that want reward, yet we don't have the prefrontal cortex to sort of regulate or put checks and balances in on that. It's because of this mismatch of developing brain components that makes adolescents more susceptible to engage in risky behaviors because of the lack of inhibition. So if we look at the mu receptors in the brain cell, especially in the ventral tegmental area that produce dopamine and release it into the nucleus accumbens, it gives rise to pleasure. And basically this is saying that we simply don't have the prefrontal cortex development to sort of regulate or control that type of reward seeking. I do want you to appreciate that the nucleus accumbens is a major part of the brain that are, again, involved with reward. So it's suggested that all motivational relevant stimuli are also regulated at the nucleus accumbens. So that means that it will seek reward, and it also will understand negative influences. So things that scare you or don't get you that reward, it can do both. So it's considered to be motivationally relevant stimulus, whether it's adverse or rewarding, but it uses the adverse stimuli in a very odd way, in the fact it figures out what's negative to get the positive, if you're following me. So it will figure out ways to direct you more to that rewarding sensation and avoid the adverse sensation, if you're following me. So the big picture is that over time, because of these natural rewards, you can't, because the drug is taking over your natural production of these different chemicals, that when the drug is removed, those chemical levels are decreased, putting you into a withdrawal situation the brain doesn't like. You don't like the way you feel. So the only way that you can feel good is to reintroduce the drug. And then you need more of the drug to get you to feel back to feeling increased levels of pleasure that you initially felt with the drug. So then we look at the locus ceruleus, and this is down in the lower part of the brain, in the midbrain, and or the brainstem, sorry. And it's important because look, this is also affected with opioids, but look at all the connections that this little nuclei does with everything. It literally can get everywhere in the brain and send signals. This is why opioids are so addictive, is because they activate centers in the locus coeruleus. So I'm going to go through this one really quickly. I think it's kind of important to know. But if we look, we talked about the neurochemical structures outside. What's going actually inside the cell is the converting enzymes and the cyclic AMP from ATP from adenylene cyclase. All that is affected by the drugs themselves. So if we look, if we have a mu receptor activates the adenylene cyclase, changes ATP to CMP to get a response. The opioid receptor, or the opioids hit the mu receptor, it inhibits the enzyme that creates ATP to cyclic AMP. As a result, less cyclic AMP is produced and more noradrenaline is released. So alertness, muscle tone, or less norepinephrine, sorry, is released. And so you get alertness, muscle tone, respiration drop, that relaxing feeling that the opioid gives you the sedation, the shallow breathing, and gives you that euphoria. And over time, your body's going to respond to that. It's going to make more converting enzyme. It's going to try to counteract what the opioid is doing. Until such time as now the inside of the cell is actually overdriving, which gives you the withdrawal symptoms of the jitters, the anxiety, the muscle cramps. So you need that further drug to remove the negative withdrawal symptoms that you're experiencing. So you quickly build a tolerance for it because you need more each time to get the same result. You begin to feel like you just need it to feel normal. And over time, you also get the negative side effects of the drug. You start to feel sick when you try to stop. So heroin is stronger and cheaper and easier to get than prescription pills. Heroin is more dangerous than prescription pills because you don't know what it's cut, mixed, or laced with. And heroin overdose often leads to death because by the time it's recognized, the level of depression is significant. And I would suggest anybody who wants to know a little bit more about how the system works,
for a lot of your cognitive functions, movement, and in some senses
I would go to this YouTube
but not to the scale
channel.
of when you're actually using drugs or alcohol. When someone uses a psychoactive substance, it unleashes an inhuman amount of dopamine, something that you can never get from any natural experience. In fact, the brain even has a hard time comprehending how much dopamine is now in the system. It releases another neurotransmitter known as glutamate. Now, glutamate is responsible for your memory functions. The more glutamate that is in the system, the more likely you are to remember this experience and in greater detail. These neurotransmitters also affect the nature of the midbrain. When you have these many neurotransmitters going on, the midbrain becomes more and more sensitive to the needs of using drugs and alcohol. And these surges of neurotransmitters also affects the nature of the midbrain. The more glutamate and dopamine that's in the system increases the sensitivity of the midbrain to drugs or alcohol, making it a higher priority in the brain's functioning. Once drugs and alcohol are introduced into this pyramid at the base, the other higher levels begin to become less and less of a priority because all the focus of the brain is beginning to become more and more centered on the addiction itself. So this would explain a lot of the physical occurrences you see in your everyday life when people are addicted, that they don't often hold their social obligations at a high enough standard. Maybe people are becoming less social when they're addicted to drugs or alcohol, or they even not show up for work. So this begs the question, if drugs and alcohol can be so dangerous to the nature of the brain that it completely rewires it into a repeated pattern of use, why not just stop? Why doesn't the prefrontal cortex actually make the executive decision that drugs and alcohol are not good and we should cease using? If only it were that simple, though. See, the issue is that we have a highly overly stimulated midbrain, and the midbrain is closer to the spinal cord, which means that all the electrical signals are going to be triggering the midbrain first before the prefrontal cortex can make an executive decision. So before anyone even has the chance to even consider whether or not picking up another bottle of alcohol or taking another shot of heroin is a good choice, the midbrain is already activated and the limbic system is already going crazy, making it imperative that the drugs and alcohol are actually a necessity of life. Even if your executive functioning does not recognize it as such, your subconscious is already screaming, wanting you to re-administer the substance. So in essence, before you even have a chance to consider the choice of addiction, most of your brain has already made up its mind as to whether or not it wants to use. So with this understanding of addiction in mind, it further enforces the need for evidence-based treatment that keeps these considerations in mind before we can actually start creating real change in treatment.
So you can see how powerful addiction can be. So let's look at where we are now in history. So there were close to 50,000 deaths due to opioids alone in 2017. Opioids kill more each year than car crashes, guns, suicide, or homicide. 134 Americans died each day in 2017 from overdoses of prescription opioids, heroin, and fentanyl. That's one death every 11 minutes. And so the opioid addiction is nationwide. There's no state that's spared. Look at the increase in heroin-related overdose since 2000. The epidemic is in California and it's in your community. Over 2,000 Californians died in 2016 from opioid-related overdoses. Opioid deaths in California are increasing. And you'll see that this is the interesting statistic, is that for a long time, heroin and fentanyl were killing way more than prescription drugs, but somewhere after around 2012, 2013, it flipped and prescription opioids overtook heroin and fentanyl. So where are they getting it from? Well, 12th graders who used non-prescribed medications in the past year, most of them were given to by a friend or relative, or they took it from a friend or relative. Most of it, some of it was prescribed to them, or they bought it from a friend or relative. And of course, you can get it from the internet. So why do adolescents use drugs? Well, a lot of it is for a coping mechanism. Up to 70% of adolescents' substance abuse have comorbid issues like anxiety, depression, mood disorders, adult, ADHD, behavioral issues, conduct disorders, stress, or physical pain. Some use it to experiment to feel good, like the people at Ridgemont High. They do it to socially fit in, where their peers are using it, and they want to achieve more. So they're competitive, pressure-filled work, and they look to use Adderall or other stimulants or Provigil or Nuvigil. And then now they have to come down. Now they have to relax. So they look to alcohol and opioids and benzodiazepines to counteract the stimulants that they're taking. So prescription opioids, teens believe that they're much safer if they're prescribed, right? They can't be that dangerous. I mean, why would we be able to get it from a pharmacy? Why would a doctor write for it? So 36% of high school seniors reported in 2017 that prescription painkillers are actually pretty easy to get. So what happens when the pills run out though? Well, if they can't find them on the internet, or they don't have a friend or relative or somebody that's going to write them prescription, they look to go to the street, and heroin has become the drug of choice for many who are addicted to opioids. And so what do you think about alcohol, prescription drugs, marijuana, and vaping? Do you think it might lead to other drugs? Well, we call these things gateway drugs, especially marijuana. And of course, now marijuana is legal in this state. So 9 out of 10 people who meet medical criteria for substance abuse disorder started smoking, drinking, and using other drugs before they turned 18 years old. And interesting definition on drinking is heavy drinking or binge drinking is considered 5 or more drinks in one setting, and hard drinking is considered 5 or more drinks in one sitting 5 days in a row or more. What that would be binge drinking. So most teens combine substances. 7 out of 10 teens who misuse prescription opioids combine them with other substances. The majority is alcohol and marijuana. So substance abuse statistics, 9.7 of all 12 to 17-year-olds are using alcohol, 8.8 of 12 to 17-year-olds are using illicit drugs. The majority is marijuana. And 9 out of 18 are pharmaceutical prescribed drugs, and they use them because they feel they're prescribed. Like I mentioned earlier, they feel they're safer. So 1 in 20 adolescents has a substance abuse disorder. And again, most of them start with tobacco, and then alcohol, and then they move their way up. And then now we know that marijuana is probably the #1 drug. So this has changed since 2016. So what do you look for in kids with this? Well, nausea, vomiting, shaking, sweating, passing out, poor coordination, itching, drowsiness, pupil size. So when they're intoxicated, they have small pupils and large pupils that dilates when the drug is missing. And then changes in behavior. They get mood swings, they become irritable, they become very hostile in some points. They have odd mannerisms. They experience school problems, attendance, grade, maybe they stop extracurricular activities. They lose interest in their hobbies. They change their circle of friends. They have lack of motivation, memory lapses, poor concentration, poor hygiene, poor decision-making. They may appear drowsy. They may have a lack of coordination. They may slur their speech, have bloodshot eyes, have periods of euphoria followed by depression. Then you start to notice missing things around your home as they're using them to sell for money. You may notice things being sold online that look very familiar to your belongings. They often are in possession of paraphernalia and other physical indicators like burn holes in their clothes, empty cellophane bags, or always wearing long sleeve shirts so you don't see the bruises from the IV injection sites. And unfortunately, we're doing a pretty bad job in this country of having enough mental health facilities to treat substance abuse disorders, especially in adolescents. We fall way short, as you can see. That only 141,000 children that had a substance abuse disorder, and these are only the public funded ones, were able to receive treatment when we think there's about 1.3 million needing treatment. The truth about drug addiction, though, it affects people from all walks of life. It doesn't matter if you're male, female, young or old, college degree, high school grad, dropout, wealthy, poor, lives in a city, suburb, rural areas. Doesn't matter if you're black, white, brown, Asian. Doesn't matter. It doesn't discriminate. How has the pandemic affected the opioid crisis? We've seen a marked increase in drug use, increased suicides, depression, anxiety, stress, uncertainty, marked polysubstance abuse and abuse. Virus keeps people from wanting to seek care, fears of infection if they venture out. There's decreased staff because of the COVID restrictions, and there's decreased access to treatment centers. The pandemic has greatly increased the issue of abuse, addiction, and overdose.
Day 25 now, there is new evidence the coronavirus crisis is taking a devastating emotional toll on millions of Americans already struggling with drug addiction. A new nationwide study found drug overdoses in the United States have jumped nearly 40% since the pandemic began. Mental health experts say this alarming increase is directly tied to the shelter-at-home orders that are causing widespread isolation, anxiety, and depression. You shoot up, you smoke, you do whatever it is you do, pop a pill, and the world goes away for a while. We're seeing a lot of people that do want help not get the help because they're afraid of getting coronavirus. Same study found drug deaths in the United States have climbed 13% over this time last year. Researchers expect the total number of overdose deaths in 2020 to exceed that figure for 2016, which was the peak of the nation's opioid crisis.
So can addiction be treated? And the answer is yes. Addiction is a treatable disease. It's difficult, but it is doable. And there's different kinds of treatment, motivational interviewing, cognitive behavioral treatment, and contingency management. Different treatments, or they offer drug-free treatments. There's an important treatment matching. Medication-assisted treatments also do help: methadone, Suboxone, and Revia, and Vivitrol. You can see that recovery is a huge continuum, and there's many blocks here you can stumble on, and you need to treat the entire person, meaning their support units. What got them here? Is it their job? Is it their relationship? Is it their parents? Is it their relatives? Is it the social interactions that they're having? Is it their school? And you have to treat all that, because if you don't address all of it, as soon as they leave treatment, they may enter the same situations that got them to consider using opioids or alcohol or their polysubstance abuse. And so how many people relapse from addiction? Well, because you don't treat all these things, it's 40 to 60%. So that's a pretty high failure rate. So what can we do as doctors? Well, we can try to limit the prescriptions. I mean, it's the fact we can't call in medications has definitely reduced the people calling in for drug seeking and getting us to call in a prescription on a Sunday. But we also need to limit our opioids to patients who clearly need them. Prescribe only the quantity of pills the patient's likely to need. Most patients take necessary opioids for a couple of days after surgery, maybe as long as 5. Use other strong painkillers that don't have a potential for addiction. So sometimes you can combine non-steroidals with acetaminophen, and they work very synergistically together. And if you have to, give small amounts of the narcotic for breakthrough pain. Be alert for signs of addiction. Be ready to ask about drug use and be able to discuss the matter, especially if they admit to marijuana use. That's definitely a gateway drug, and we, at least in my practice, and I know other practitioners have found that those patients are typically harder to sedate. They also use typically more narcotics than the non-marijuana users. Don't be afraid if you're in a situation where you feel uncomfortable to prescribe. Refer them to a treatment professional or another specialist. Don't be judgmental. Be optimistic and reassuring when you're talking to these people. Just reduce the stigma by talking about the issue in a non-judgmental fashion. Helps them be more honest and upfront with possible addiction issues. So screening, what can you do? Well, you can check Cures. So Cures is a database that has all scheduled drugs that have been prescribed to that person. And that's very helpful. We all had to become part of Cures, if you recall, back in 2018. But I don't know if anybody's ever checked it. I leave it open every day. And so when I'm writing prescriptions, I just simply search the patients by name and date of birth. And that lets me know how many people have been prescribing for this patient. Is there a current substance abuse issue? Is there a risk of abuse or diversion? Is there a possible drug interaction? Is there a family history of drug issues? Is there a mood disorder? That's going to tip you off that this may be more susceptible. So anxiety, depression, psychosis, or ADHD. Should an alternate therapy be considered? So does the parent seem interested in pain management of the adult child? A lot of times they come in and the parents are the ones with the issues, and they're using the child as a proxy to get that script. So do the parents or the child ask for a particular pain medicine? That's usually a tip off. And should you refer the case to a pain specialist? If you find yourself with finding that there's no reason for this person's pain and yet they're requiring more and more pain medicine, that's the time you should probably refer it out rather than getting caught in that terrible cycle. So go low and slow, the lowest possible effective dose just for as long as you think they may need it. Consider combining it with non-narcotics. In an acute pain situation, 2 to 5 days is usually sufficient. Considering deferring the patient to a specialist or a chronic pain management doctor. Use the drug monitoring program. The prescription drug monitoring program in this state is called CURES. Definitely use that. You can see if other opioids are prescribed, when and how many, and the other controlled drugs like the ADD drugs or sedatives. That can help you see if this patient has a potential for polysubstance abuse. And I tell you what, when you do see that they've been prescribed a lot of pain medicine from different prescribers and you show them that on the CURES site, let me tell you, they take a couple of steps back and then they're not so pushy with the prescription requests because they know you're sort of on to them. If an adolescent puts the parents in charge of the medications for their distribution, that's helpful, as long as, of course, the parents aren't flagged on the CURES site. And when done, make sure they properly dispose of the narcotic medication, as having them around is always a temptation. So education, very important. Keep up and be informed with the new drugs and the new current habits, and especially habits about addiction and what is on the street. Educate the patients on the risk of opioids. Educate about the bad habits of keeping old opioids around the house for the just in case I may need them excuse. Tell them where you can dispose old or unused drugs, including narcotics. Most pharmacies, hospitals, police departments have disposal receptacles or programs. You can always search it on the FDA site. Tells you where all those are based on your location. And if you do keep them around, keep them hidden or locked up. Document discussions. California law, the Bates law, the SB 1109 requires that you have a discussion with a minor and a parent if a narcotic is prescribed. So in my office, I use all these different things. Certainly if I'm going to write for a 2 or 3 day course of some pain pills after a complex wisdom tooth removal or a post-jaw surgery on a minor, the parents are signing this. We use different informational guides to help our staff understand how they should be talking to particular people who may be with that minor. We give patients educations on opioid use before we prescribe. And then everybody gets this in my office who is prescribed an opioid. So addiction can strike anyone. There, again, is no immunity to the disease. I zipped my daughter up in a body bag and helped them carefully place her on the cot. Is something I hope none of us have to experience. So the lady I talked to at the beginning, Natalie, the high school students, there was a poem that was read at the beginning, was taken from the Pennsylvania's coroner report. The poem was shared by her mother. The mother had asked the poem be shared in hopes in reality, it could help prevent others, mothers, fathers, brothers, and sisters from having to share in the devastation of a loss of a child. That's her gravestone over on the lower right, and on the lower left, Nat Shack is the mom's awareness group that she's put together about Natalie to raise money and for opioid education for adolescents. So I want to have a special thanks to the California Association of Oral and Maxillofacial Surgeons. They put together a program where some of the slides and data I took from for Saving Our Children Through Opioid Education, which is a lecture, very interactive lecture with the slides that you can give to high school students and middle school students about the effects of opioids and the risk of addiction. And it's something I've done, and you'd be surprised when you ask how many people know somebody or have a family member that's been affected by opioid abuse. And when I went, at least to the high school that I presented at, you saw about 1 in 4, maybe as high as 1 in 3 people raise their hands. And then now they offer their story. It's pretty mind-boggling, some of the stories that are told. So it definitely has affected many different people, and it is definitely pervasive in our society. So I'm done tonight, but I just wanted to quickly go through the references. So on the recording, you'll have them if you want to look anything up. There's several, but a lot of these references are pretty good. So just hold on a second while I get through this, and then we'll conclude. So thank you very much.
Yeah, thank you, Dr. Bohannan and Dr. Abramson. That was a fantastic webinar. We look forward to our next webinar. So that concludes tonight's program. So thank you all for coming.